Right, I'm going to start off this afternoon's talks by looking at some of the techniques, so the specific nerve block techniques. So we're going to start with those looking at the thoracic limb. So thinking about the innervation to the thoracic limb and the main nerves that we can look at actually blocking to desensitize areas for surgery. So we're going to go through the radial, the musculocutaneous, median and ulnar nerves, which are our primary ones that we think about blocking in the forelimb. We'll mention briefly the axillary nerve, which can be accessed from doing a brachial plexus block that's often missed when we do the brachial plexus block. And all of these nerves exit from these segments of the spinal cord from C6 through to T1. So initially thinking about the radial nerve, so anything from spinal segment C7 to T1. The colour's not come out amazingly well here on the slide, unfortunately. But we're aiming to desensitize the skin on the dorsal aspect of the antebrachium, and it's also going to affect or innervate the elbow extensor muscle. So that's going to be the movement that we might associate if we use electroneurostimulation to perform this part of our block. So primarily from C7, 8, and then T1. It also may block some of the skin on the dorsal aspects of the paw, except the most lateral, the fifth digit, and some of the skin over the metacarpal bone and the palmar surface of the paw as well. The next nerve down is the musculocutaneous nerve, so exiting perhaps a little bit more cranial, so primarily from C7, can be from C6 and C8 as well. This one is our skin on the craniomedial aspect of the antebrachium, and it's also innervating the biceps and the brachialis muscles as well. So we're going to see flexion of the elbow when we stimulate this aspect of the nerve, and we're going to block, as we mentioned, the medial aspect of the forelimb. The median nerve, again, C8 to T1, maybe a little bit from T2 in some patients. This is going to provide sensory denervation, or sensory innervation, to the caudal aspect of the paw, and also innervate the carpal and digital flexors. So we're going to see carpal flexion when we stimulate this nerve, and it's going to cause pronation of the limb as well. Finally, of our group of nerves that make up that plexus that we'll later discuss as the brachial plexus, we've got the ulnar nerve, again C8, T1, maybe a little bit from T2 as well. We're going to see carpal flexion, and it's going to block the caudal aspect of the antebrachium from our ulnar nerve, and also digits 4 and 5 on the lateral aspect of the digit of the paw as well. So finally, the axillary nerve, and as I mentioned, we often miss this nerve, so we miss its innervation with a traditional brachial plexus block. Again, C7 to C8. This is going to innervate the shoulder flexors, and it's also the skin of the craniolateral aspect of the antebrachium, so from our axillary nerve up here. So one of the blocks that we can use to block all of these nerves together is the brachial plexus block. So we can look here at our dog. So we've got head up at this right-hand side of the screen, and then just drawn on is the position of the scapula and the position of the humerus. You can see this needle positioned through outside of the skin there, just for reference. So if we look into the anatomy within the area of the brachial plexus, then we can see the nerve segments that we were just talking about there. So primarily C6, 7, 8, T1, and where each of the nerves comes through to form in this plexus here, which is going to be the aim of our block. Now we can either perform this as a blind injection, or we can use electro-neurostimulation as well. So there's a video in a couple of slides just showing performing this block with a nerve stimulator. So we're obviously aiming to place local anaesthetic in close proximity to the nerves that we mentioned, so the radial, ulnar, median and musculocutaneous nerves. Hopefully we might get the axillary nerve as well, though we often miss this unless we perform quite what they describe as a high or a high brachial plexus block. So we're aiming then to introduce our needle, as we saw on that previous slide. We want to be obviously medial, cranial to the, where's gone? Cranial, obviously, we're aiming for the scapulohumeral joint or the scapuloglomerular joint. We want to be medial to the subscapularis muscle. We want to be parallel to the thoracic wall. We're obviously aiming to block underneath the scapula. We don't want to enter the thorax. So one of the complications associated with this block is creating a pneumothorax. So we want to do all we can to obviously make sure we enter the axillary space, but we don't want to go through into the chest. So it can help with positioning. So we want the affected limb up, or the limb to be blocked uppermost. Maybe have an assistant lift the leg up for you just to ease access into that area. So we want to use a spinal needle for these blocks. We need some sufficient length to perform them. And we want to be aiming as our landmark for our caudal aspect of our injection is going to be the first rib. This needle shows perhaps it's a little bit too sort of just going caudally, but we want to probably aim in a caudodorsal direction with our needle. And our aim is then obviously to deposit local anaesthetic within this area. If we're doing it with a blind technique, then we can just inject as we go on, obviously aspirating, as Matt mentioned, prior to each injection. If we're using neurostimulation, as we see in the video later, we can actually localize each of the nerves individually and block them in that respect. So what's it useful for? As we mentioned, anything of the thoracic limb, probably anything distal still to the elbow, unless we perform a higher version of the block where we're going to direct our needle more dorsally in the patient to make sure that we block the axillary nerve. So useful in terms of, the other thing up here is for amputation, we actually get the surgeon or yourself to actually deposit local anaesthetic around the brachial plexus nerves before you then remove them when you're doing a 4/4 amputation. Again, just a slightly different angle. You can see with the needle here, we're just pointing slightly more dorsally than on that previous slide. So this is really the direction that we should be aiming for. And it's useful to palpate up here to give yourself an idea of where you should be directing that nerve. Dose-wise, we want to make sure that we've calculated our toxic dose. So if we're using bupivacaine commonly for this block, we want to make sure that we don't obviously exceed 1 to 2 milligrams per kilogram total local anaesthetic volume. In a smaller patient, you may want to dilute that local anaesthetic so you've got sufficient volume to perform the block. If you're ending up in a small cat, for example, where you've not got sufficient volume. So what do we know from an actual local anaesthetic volume-wise that we should be aiming to place around each of these nerves? So this is obviously a study in people. They aim there that they worked out from a staining point of view that we needed to actually see 2 to 4 mils per nerve to actually provide local anaesthesia for each of those nerves. And even when they did this, then 7 out of 19 patients required some further local anaesthesia during surgery. And 2 out of 19 required some additional IV analgesia, so things like the potent short-acting opioids. And this was even using ultrasound guidance. As Matt mentioned before, we want to see if the local anaesthetic has actually surrounded the nerves rather than just moved down a fascial plane away from where we've directed it. So we'll just show a video of, this is Matt performing a brachial plexus. This is a blind brachial plexus block. So we're not using neurostimulation to do this. So you can see the patient's head's up at this end, so we've got the forelimb here. You can see Matt placing the needle through there, so we've gone medial to the subscapularis muscle. And just obviously then we've palpated through, we've got our direction, see there, dorsally directed. Connect up, obviously, our syringe with our local, aspirate before we inject. And you can see Matt's technique here, he's actually moving the needle, withdrawing the needle as he's injecting the local anaesthetic. So that would be one technique. You can also fan local anaesthetic around, so you can change the direction of the needle as well if you're performing it via the blind technique. Obviously with using neurostimulation, then we're looking for each of those individual nerves in terms of actual movement associated with them so that we know we've blocked each of them. It's easy with this technique to potentially miss one of those blocks and see a patchy block appear. So what might be an alternative to performing the brachial plexus block? Obviously, there's the potential for some complications associated with it. We can't necessarily always avoid things with that. So we could use the radial ulnar musculocutaneous median block, our run block instead. It's an alternative to the brachial plexus block. And here we're aiming to identify individual nerves more distally in the limb, rather than obviously going for them up into the brachial plexus itself. Again, it's only really indicated for distal limb surgery, so probably more distal to the elbow than the brachial plexus block. We need to identify the 3 separate nerves. Again, we can do this as a blind technique, and you can often palpate them. We'll go through the location of each of the individual nerves. You can palpate them over the humerus, but obviously the neurolocation, electrical neurolocation, improves our accuracy in being able to identify each of them individually. So these are some diagrams from a study that looked into the efficacy of the run block in the dog. So this is the medial aspect of the forelimb. You can see them aiming here actually for the this is the musculocutaneous nerve, so they're palpating it on the medial aspect, probably distal third, and just moving the biceps muscle slightly cranially there to block. Some people will, with the blind block, they'll aim to block the ulnar, the median and the musculocutaneous with one injection, and that's certainly feasible without neurolocation. On the lateral aspect of the forelimb here, we've got the radial nerve. This one actually, in most dogs, you can palpate it quite easily in about the distal third to the middle of the forelimb. You can actually feel it as you palpate it. You can move it over the humerus. But its location is usually relatively fixed. If you can obviously locate it, it's very easy to deposit local anaesthetic over it. So here, just a dissection of the forelimb again. So we've got the brachial plexus that's up here, the elbow, and we're aiming to deposit local anaesthetic here for our ulnar and median musculocutaneous blocks. You can palpate the ulnar nerve over the olecranon, but we shouldn't really aim to block it down here. Certainly if we block at this level, we're not going to get very good anaesthesia for a considerable amount of that lower part of the antebrachium. So it's much better to try and block at a more proximal site. So just an idea of some positioning for performing the run block. Again, patient in lateral recumbency with the limb to be blocked uppermost. You can see here that we are using electrical neurolocation, and we're aiming for the radial nerve here on the lateral aspect of the forelimb. I haven't got a video showing this, unfortunately. As I mentioned, we can often palpate it at the junction between the middle and the distal thirds, but using neurolocation aids us in our accuracy of placing our local anaesthetic. Actually, I find a lot of the time it's very easy just to do this without any other additional help. From that same position, we can then lift the dog's forelimb, raise the forelimb, and we can block the ulnar and the median and the musculocutaneous nerves. At this level, we can use electrical neurolocation to associate with the ulnar and the median nerve, but the musculocutaneous nerve is purely sensory down here, so we don't see any associated muscle contraction with the musculocutaneous nerve. So we'll look at a video now of the the radial nerve block. If I can get the thing on. We've got the same here. We've got our positive electrode here. The mat's entering the needle there, so we can see some nice elbow flexion there, and also some carpal flexion as well. So that's just reduced down the current to 0.3. We've lost the muscle twitching at that response. Just aspirate again as before, and then inject our local anaesthetic as for the other techniques. And then just one more video, just looking at now at blocking the ulnar and the median and musculocutaneous nerves. As I said before, you can block pretty much these three nerves in the same location. If you're doing it blind, you can block the median and the musculocutaneous separately to the ulnar nerve. So you can see some carpal flexion here. And again, the most important thing when we're using the nerve stimulator needles, as Matt mentioned, is that only the very tip of the needle actually conducts the current that you're giving. So any other movement, any movement of the needle needs to be quite small, otherwise you can very easily move away from where the nerve actually is. So it's all about small movements, very gentle movements, not excessive. Otherwise, you can be quite distant from where you are aiming to inject. So we'll move away from blocking the brachial plexus or our run block to look at some more distal. Obviously, those blocks are useful for any surgery, but it might be that we want to do something down in the region of the paw. And our blocks higher up may be considered to be a bit potentially excessive for those procedures. So something like removal, for example, of a grass seed, or searching for a grass seed within the interdigital spaces, removal of a toe, things like carpal and tarsal arthrodesis as well. Then we've got three techniques that we can use. We can do a ring block up at the level here of the carpus. We can do an interdigital block very easily, where we can just inject local anaesthetic either side of the digit and aiming for those digital nerves as they come down into that region. And then finally we can use IVRA, which is intravenous regional anesthesia, which we'll talk about as well. So the ring block, a useful technique, as I mentioned, for anything where we're exploring in the interdigital region. We want to obviously keep potentially local anaesthetic away from this area. If you want to perform surgery here, having instilled local anaesthetic there may hinder your surgical exploration. Digit amputation, perhaps things like nail surgery as well. Hopefully this video should work as well. So you can just see here that we're just going to start with locating our landmarks. So just a couple of needles, slightly offset to lateral and medial aspects of the limb. Again, calculated our dose of local anaesthetic that we're going to use. Obviously aspirate first and then inject, then move the needle as you inject. So we can simply perform in quite a simple block. So once we've put our needle in and we've drawn in one direction, we can just switch the direction of the needle and inject through into that second injection. I'm sure, yeah, so you can just see there as well, like Matt was talking about previously, that in this situation where we've now caused a hematoma, then we should stop injection there if we see blood aspirated. And obviously, there's no harm though in moving round to that second needle we place and injecting local anaesthetic here. Probably not advisable to continue to inject local anaesthetic in that area where we know we've gone into a blood vessel, particularly if we're using bupivacaine.
So how would you complete the nerve block?
Well, I think you would hope still that we'll get diffusion of local anaesthetic. We've created some space there in the subcutaneous tissue, so we should see diffusion of anaesthetic, of our local anaesthetic around there. And you can see there Matt just massaging that area as well to encourage the local anaesthetic to move around the limb. And again, just on the caudal aspect of the limb there as well. So it's important to use the block all the way around. So obviously something that takes a little bit of time, can require relatively large volumes of local anaesthetic. So again, in smaller patients, you may need to dilute your local to do that. But a nice technique, relatively easy. We don't need any specific landmarks to do this technique. The next one to look at is our technique of intravenous regional anesthesia. Again, for anything of the lower part of the limb, so it's good for any surgery on the pads, any digit surgery, any nail surgery again, things like digit amputation. An advantage of it as well is that we're going to actually aim to exsanguinate or at least place a tourniquet onto this limb, so it's going to reduce any hemorrhage in your surgical site during the surgery as well. So we need to catheterize a vessel in the distal part of the limb, so any vessel that you can get access to. Ideally we want to use an intravenous cannula to gain access into that vessel. We need to do that prior to placing to actually exsanguinating the limb or placing your tourniquet so that you still can tell that you've actually accessed that blood vessel. I only haven't said that because I've done that before where we've exsanguinated the limb and then I've tried to do it and it doesn't work. So you can see here then we've used our Esmark bandage to exsanguinate the limb, and then we tie a tourniquet at the more proximal aspect of the limb. Vet wrap's quite useful to this because you can put it on pretty tight. Obviously it's a bit kind of alien to what we normally want to do with vet wrap, where we're trying to put it on as loosely as possible, but it provides a good tourniquet as well. So once we've done that, we can then cut the vet wrap up to our place where our tourniquet is, secure our IV access obviously at this point, and then we're going to use lidocaine for this block. As we mentioned before, it's something that it's the only one, if we're injecting a local anaesthetic intravenously, we want to just use lidocaine. We shouldn't be using any of the other local anaesthetics to go IV. So particularly bupivacaine, levobupivacaine, ropivacaine are all quite cardiotoxic at relatively low doses if they go IV. So not via that route. Lidocaine absolutely fine. Again, dosing of sort of 2 milligrams per kilogram in this for this block. I suppose important things to consider is how long do we want to be leaving the tourniquet on for. There's some concerns about things like reperfusion injury if the tourniquet is left on for more than about 30 to 45 minutes. You have to make sure it's a surgery that's not going to be particularly prolonged. And the other thing to be aware of is that as soon as we remove this tourniquet at the end of surgery, one, we might see some hemorrhage from our site if it wasn't controlled, and the other is that the local anaesthetic is going to be redistributed away from that area, so we're going to lose the analgesic effect of our lidocaine as well. So it's not, although it's a useful technique, the brachial plexus block and the run blocks are probably more useful in providing good sort of perioperative analgesia. This is not something that's going to last into the recovery period. So Matt mentioned a few of the studies that are currently being looked at as to how we can improve our neurolocation, and obviously ultrasound guidance is the main area where we're looking at the moment to actually make sure that we think we've injected local anaesthetic next to our nerve, but where does it actually go when we make that injection, and why does our block, as we mentioned, why does our block not work? Everything looked really good, and then actually the block wasn't as successful as we would have hoped it to be. The other approach that we can use to the brachial plexus block is the axillary approach, and I tried to find a picture of a dog lying on its back just to illustrate this. That you would lie the dog in dorsal recumbency and actually pull the leg cranial, so you can access the axilla from this cranial aspect rather than going in at the side like we were doing with the dog in lateral recumbency. And certainly there's shown to be some benefits here. It actually opens the axillary space up. It may be easier to locate the nerves associated with the brachial plexus by doing this. I mentioned the high brachial plexus block where we're really aiming to try and block that axillary nerve, and we're going quite dorsal with our needle in performing that. And a few people in the States have looked at this other technique of actually performing something similar to in farm animals where you do a paravertebral block. You can do a paravertebral brachial plexus block as well. I've only tried it once. It's a real faff and it didn't work. So, and that was with a nerve locator as well. So it probably isn't, it hasn't really taken off. You have to try and palpate the transverse processes of the vertebrae and move the scapula out of the way. It's not an easy technique. So I would be advocating the more traditional brachial plexus block. This is nice. I like this because it gives you a lot of space to perform the block, and it keeps you away from the thoracic wall as well while you're doing it. Or trying the run block as well. So it's a nice technique, and as I mentioned, you can often palpate those nerves quite easily to perform the run block.